Hi, I am Dr. Saqib Mansoor from my channel Learning Anatomy, and today I will discuss with you the femur anatomy. Femur is the strongest bone of the body, and it is the longest bone of the body, and it's also called as the thigh bone, right? So obviously, like every long bone, it has an upper end. Here is the upper end and the lower end. This is the lower end of the femur, and a shaft. You could see this is the shaft, and here you see in this picture the articulation of the femur is shown above with the hip bone, right? This is the hip joint, and this is a hip bone. So you follow my laser on the right side, and this is the femoral head, and articulating with the acetabulum of the hip bone, forming the hip joint. And here you could see this, and these green areas are the subcutaneous areas, which you can feel from the skin. And this is a complete picture of the your hip femur, right? This is on this anteriorly, and this is the posteriorly. So femur consists of a long shaft. A neck proceeds upwards and medially to a rounded head, and a greater and a lesser trochanter projects from junction of shaft and neck. Here you could see this is the head. This is the head of the femur, right? And you could see anteriorly this head as well. This is the fovea for ligament of head, right? In the center of the head, this is fovea or depression. This is the anterior neck, and this is the posterior neck. This is the head, this is neck, and anteriorly there is a intertrochanteric line here as this point, intertrochanteric line, and posteriorly is lying the intertrochanteric crest, right? So this is the way with it. At the upper end, these structure are visible, and posteriorly this is the quadrate tubercle you could see over here, and this is the greater trochanter, and this is the lesser trochanter, right? And from anteriorly this is the greater trochanter, and this is the lesser trochanter, right? And at the upper end these structures are very marked. Shaft ends distally in a pair of large condyles. In standing position, shaft travels downwards and medially, and this inclination is prominent when the femur is lying vertically with both its condyle in contact with a horizontal surface. Femoral obliquity is more in females because of the relatively greater pelvic breadth and the shorter femoral length, right? So this is the way with it. This is you see obliquity of the femur. This is oblique, right? And again, you see this is the lower end and the condyles. This is the lateral condyle, and here this is the medial condyle. This is the medial condyle, and this is the lateral condyle. So talking about in detail about the upper end of the femur, about the head of the femur is covered with hyaline cartilage, and it is more than half a sphere. Its medial convexity bears up at the fovea for the ligament of the head. I've already told you. Anteriorly, the articular cartilage extends a little onto the neck. You could see this is the head covered with the hyaline cartilage, and there is a fovea for the ligament of the head. And you could see also these lines as well, even from here. And thus, this line is for the attachment of the border of the synovial membrane, this reddish line. Here you could see this is one line, this one line, and this is another greenish line. This is so you could see here line for the attachment of the fibrous capsule, right? And again, in this beautiful picture, you could see this amazing indeed. This is head, and this is the greater trochanter. This is lesser trochanter, and this is the view from the lateral side. This is the head, and this is the fovea. You could see how clearly there is a depression for the ligament of the head of the femur, and these are attachment of the various muscles, which I will tell you later on. So let's talk about the neck of the femur. As neck of the femur inclines upwards and medially, it forms an angle of about 125 degrees with the shaft of the adult male. And this angle of inclination is widest at birth and diminishes until adolescence. It is less in females. Neck is also tilted forwards slightly as it passes proximally to head. This angle of anteversion is about 10 to 15 degrees. So two angles, angle of inclination and angle of anteversion. Here you could see this is, head, and this is neck, and this is shaft. And you could see now this contemplating about the angles. And let me zoom in the picture for you for clarity. Here you could see this. And this is the long axis of the head. Follow this hand cursor's long axis of head and neck. You should see this. And this is the long axis of shaft, right? Here you could see this. This is an angle being formed. And then again, this is, this angle of inclination, you see, here it is formed between the long axis of the head and neck. Here you could see this. And this is the long axis of shaft. This axis is the angle of inclination, 125 degree in males, right? So you could see there is a hand cursor. Yes, this, you could see this. This is the angle of inclination. And moving on again, angle of inclination in a 3-year-old child, it is greater, 135 degree, and it decreases in adult to 125 or 126 degree, and the angle of inclination in old age also diminishes further to 120 degree. Again, the angle of inclination is between the axis of the femoral head and neck and the long axis of the shaft of the femur. It's a beautiful picture. You focus on to this. This is, you can see, torsion angle of femur. Another angle. This is the head and neck. Here you could see axis of the head and neck. And you could see this, the shaft of the femur, right? And this angle is here. You could see this. This angle is the torsion angle of femur, the angle of femoral torsion, right? I think you'd be able to see this quite clearly between long axis of the shaft of femur. Here you could see this, and head and neck axis, and this is a torsion angle of the femur. Femur ridges on the surface of the neck, especially on the anterior aspect, indicates the attachment of the retinacular fibers of the hip joint capsule, which are reflected proximally from distal attachment of the capsule. Anteriorly, capsule is attached to the intertrochanteric line, which extends from the greater to the lesser trochanter, where the neck joins the shaft. Here it is. These are the retinacular foramina, the ridges, right? Retinacular. Posteriorly, capsule is attached halfway along neck between articular margin of the head and the prominent intertrochanteric crest, lying at the junction of the posterior surface of the neck and shaft. You could see this is the posterior aspect, and this is the attachment of the capsule, right? And you could see this line of the attachment of the fibrous capsule, and it is lying over here, halfway between from the head to the intertrochanteric crest. This is the attachment. You see the laser. This is the attachment of the fibrous capsule posteriorly. Tendon of the obturator externus plays on smooth bone of the neck distal to the posterior capsular attachment. Many vascular phenomena that are directed downwards ahead perforate anterior and posterior surfaces of the neck. Now, talking about the blood supply of the femur. In an adult, head of the femur receives its blood supply mainly via these phenomena from blood vessels, mostly from trochanteric anastomosis, and especially from the medial circumflex artery that run up the neck with the retinacular fibers of the capsule. These vessels and intramedullary vessels that run up the neck from the shaft are liable to be ruptured by a transcervical intercapsular fracture and avascular necrosis of the head femur. It's very important clinically, avascular necrosis of the head of the femur. So it's a potential hazard. Blood supply to the head from vessels that accompany the ligaments to the head is sparse in the adult. Here you could see these vessels. This is the anastomosis between medial and the lateral circumflex femoral arteries. You could see this. This is the anastomosis, right? Here you could see this. This is a medial circumflex femoral artery over here, right? You see over here, this. And these are the retinacular arteries, which are subsynovial, superior, anterior, and inferior. These are involved in the blood supply here to the head, upper end of the head of the femur. And this is the acetabular branch of the obturator artery, often minute in ligament of head of femur. And here you could see also medial circumflex femoral artery. It's the main branch supplying the head, and this upper end medial circumflex femoral artery. Here you could see this. And this is the anastomosis I was talking about previously to you, right? You see this picture. It's a beautiful picture. These are the retinacular arteries. You could see over here, this three: superior, posterior, and inferior. Again, over here, you can see this in more clarity. This is the medial circumflex femoral artery over here, right? So you see its branches to the upper end. And this is the lateral circumflex femoral artery over here, right? And this is medial circumflex femoral artery supplying the upper end. This is all head and neck, greater trochanteric, the lesser trochanteric. Here you could see medial circumflex femoral artery over here, giving the branches up. Now, the greater trochanter of the femur projects up and back from the convexity of the junction of the neck and shaft. Upper border of the greater trochanter is projected into an interned apex. Here you could see this, right? You could see, and this projects up and back. It's up and back. This is the greater trochanter, up and back from convexity of the junction of the neck and shaft. This is the neck. This is shaft, and from this junction, this is projection up and back. You could see this is the greater trochanter. It has an apex as well. You could see this is the apex. Now the attachments. Piriformis muscle is attached at the apex at the medial site, right? Piriformis. You could see this is the piriformis muscle. This follow the laser. This is the piriformis muscle. It's big enough, no need to enlarge that. This is the asterisk with it. This is the piriformis attached to the apex of the greater trochanter. Moored anteriorly on the medial surface of the greater trochanter, common tendon of obturator internus and the gemella is inserted. You follow this. Obturator internus and superior and inferior gemella tendon. Like here you could see. Here it is inserted over here. No, I need to enlarge that for the purpose of clarity. Here you could see. This is piriformis, and this is the common tendon for attachment of the obturator internus and the two gemella, superior and inferior gemellus. So this is the way with it. Anterior surface of the trochanter possesses a J-shaped ridge for the tendon of gluteus minimus. Now we have to follow this gluteus minimus for this, you say J-shaped ridge. This is the attachment for the site of the gluteus minimus. So you could see. This is the asterisk for that. And let me go here as well. This is a gluteus minimus tendon over here to the greater trochanter, gluteus minimus. Anterior surface of the trochanter and lateral surface of the oblique strip sloping downwards and forwards for the tendon of the gluteus medius, right? Lateral surface has the oblique strip. Now the gluteus medius. Here, this is the lateral surface. This is the attachment of the gluteus medius, right? Gluteus medius. Again, you see this. This is a beautiful attachment laterally in the gluteus medius on the greater trochanter, right? Here is the greater gluteus medius. Also, this classical picture. This is a classical one. This is the, going back, you see this is the gluteus minimus and this is the gluteus medius. So femur apex of the trochanter is lying at level with the center of the head of the femur. The prominent convexity of the greater trochanter is lying at the widest part of the hips. It is covered with the beginning of the iliotibial tract, where gluteus maximus is inserted. This plays freely over a bursa lying on the bone. So now the attachment of the gluteus maximus. Let's see that. Where is it? Gluteus maximus. Here, this is the gluteus maximus muscle attachment on over here. This part, and this is the gluteus maximus on over here coming down from above. This is upper attachment, and this is the lower attachment on the femur. This is the gluteus maximus. Posteriorly, the apex of the greater trochanter continues down as a prominent intertrochanteric crest up to the lesser trochanter. Above halfway down the crest is an oval prominence. The quadrate tubercle showed you already. The quadrate femoris gets attached here. Quadratus femoris attached to the quadrate tubercle. Here you could see this is the quadrate tubercle and the quadratus femoris muscle attaching here. Let me zoom in for you. This is the quadratus femoris muscle being attached to the quadrate tubercle. And now this was a greater trochanter discussion, and now the lesser trochanter. It is lying back on the lowest part of the neck. You could see this is the lesser trochanter. Lowest. This is the neck, and this is the lower part of the neck. It's lying over here. Its rounded surface faces medially and is smooth as the psoas major tendon is received here. Psoas major, right? So let's see where is this psoas major. This is the iliopsoas muscle, iliacus and psoas major. They are attached to the lesser trochanter. It's a common tendon, iliopsoas. From this view, this is the iliopsoas muscle attached to this posterior view. So iliacus gets inserted in front of the tendon and into bone below the lesser trochanter. So shaft of the femur, right? Shaft of the femur possesses convex anterior surface and is buttressed by a strong bony ridge, the linea aspera at the middle third of the concave posterior surface. So the posterior surface of the shaft has a great, important, very important landmark. This is the linea aspera, right? You see and go like this is the posterior aspect, and this is the linea aspera. And let me zoom in this picture for you. Here you could see, let me zooming in this. You could see this is a posterior aspect of the femur, right? And this is the linea aspera, which has two lips, medial lip and a lateral lip. Linea aspera provides various attachments of the muscles. And below this diverges into this lateral supracondylar line and the medial supracondylar line, these lips. This narrow ridge linea aspera has medial and lateral lips, shown you already. Intertrochanteric line. What is that? It slopes across the front of the neck and shaft at their junction and continues down below lesser trochanter as the spiral line that runs into the medial lip of the linea aspera. Intertrochanteric line. Medial lip is continuous as medial supracondylar line to adductor tubercle on the medial condyle. I showed you already this, right? These both medial and the lateral supracondylar lines. On the back of the shaft below the greater trochanter lies a vertical ridge, the gluteal tuberosity. For the insertion of the lower quarter of the gluteus maximus, it travels down into the lateral lip of the linea aspera, and this lip is continuous as the lateral supracondylar line or two lateral epicondyle. I've shown you already these things, and let me show again. No point in that. You could see this femoral shaft, which has this anterior surface. This is a lateral margin, right? This is the lateral aspect. This is a lateral surface, and this is the linea aspera, and this is a medial surface. It's a medial aspect. It's a lateral. This is the medial margin, and this is the anterior aspect, and this is the anterior surface. And you could see this is the articulated one, the pelvis, and this is the femora, this is tibia and fibula, all the bones. Right? You could see this. I showed you already this. This is again, you could see this. This is a gluteal tuberosity, and this is the linea aspera, the line. Intertrochanteric line in its lower half provides origin to the vastus medialis. Now you could see this vastus medialis that arises in continuity below this along spiral line, medial lip of linea aspera, and upper 1/3 of the medial supracondylar line. The lower part of the vastus medialis muscle comes from the adductor magnus tendon and not from the bone. So let's see this intertrochanteric line, where the vastus medialis is coming. You could see this is the vastus medialis muscle, right? You see this is coming over here. And let's enlarge that for the clarity purpose. You could see this is a vastus medialis muscle, right? Up from here, going down. This is the vastus medialis coming down up till this point. And the medial surface of the shaft of the femur is a bare bone, right? Over which vastus medialis plays. Vastus lateralis, no, the vastus lateralis takes origin from the upper half of the trochanteric line, the lower part of the greater trochanter, the lateral edge of the gluteal tuberosity, and the lateral lip of the linea aspera. Vastus lateralis. You could see this, vastus lateralis. Let me zoom in for you. This is the vastus lateralis muscle. This is its complete origin. Going down, down and down, up till this point, vastus lateralis. This is the vastus lateralis. Then the vastus intermedius takes origin from the upper 2/3 of the front and the lateral surface of the femoral shaft, vastus intermedius. This is the over here, you could see, and let me zoom in for you for clarity. Here you could see this. This is vastus intermedius. Here you could see this. This is coming down, vastus intermedius, going down up till here. Articularis genu takes origin from the front below the vastus intermedius. You could see this. This is the articularis genu. Here you see, very clear, articularis genu. So now the pectineus muscle gets attached to the upper part of the posterior surface of the femur behind iliacus, pectineus. This is the pectineus muscle, right? Let me enlarge again for you. Here you could see this is a pectineus. This is the pectineus attachment. Adductor brevis gets attached behind the pectineus and down to the proximal part of the linea aspera. Adductor brevis. Let me show you. This is adductor brevis, and let's enlarge that. This is the adductor brevis. You can see behind the pectineus. You see here this adductor magnus. Here you could see this. This is adductor magnus attachment, right? In down. And the adductor magnus gets inserted medial to the gluteal tuberosity below and the quadratus femoris, and then along linea aspera to medial supracondylar line and down to adductor tubercle. There is a gap in the supracondylar attachment, a hand's breadth above knee, through which femoral vessel pass into the popliteal fossa. Femur. Between adductor magnus and vastus lateralis muscles, a short head of biceps femoris takes origin below the gluteal tuberosity from the whole length of the linea aspera. Short head of the biceps femoris. And let me show you. Yeah, this is the biceps femoris muscle, short head. Let me enlarge for you. This is the biceps femoris, short head. Between adductor magnus and vastus medialis, the adductor longus gets inserted into the middle third of the linea aspera, adductor longus. Here you see, this is the adductor longus muscle. Here you could see this. Again, zooming in. This is the adductor longus muscle, dashed here. Popliteal surface of the femur between supracondylar lines is bare. Anterior surface of the lower shaft is also bare below the origin of the articularis sinu, with the suprapatellar pouch in contact with the periosteum deep to the quadriceps tendon for a hand's breadth above knee joint. This is the popliteal surface. Let me show you. This is the popliteal surface here between the medial and the lateral supracondylar lines. This is the popliteal surface. Now the lower end of the femur. Lower end of the femur bears two condyles separated behind by the intercondylar fossa, but joined in front by the trochlear surface for patella. So, right, it is separated behind by the intercondylar fossa, but in front joined by the trochlear surface for patella. Right, you could see this is anterior. This is patellar surface, right? And here you could see this is the intercondylar fossa. These are the condyles. These are separated by the intercondylar fossa here, and this joined here by the patellar surface. Lateral condyle projects more forward than the medial condyle, thus contributing to stability of the patella. Both condyle are almost flat inferiorly, but boldly curved on their posterior convexities. So you could see here attachment with the patella. This is the femur, and this is the patella attaching with the. This is the femoral patellar articulation over here. In intercondylar fossa, cruciate ligaments get attachment to smooth areas, where anterior cruciate ligament is attached far back on lateral condyle along the articular margin. You could see this. This is the anterior cruciate ligament, right? And this is the posterior cruciate ligament. And this is anterior cruciate. You follow the attachments over here. Again, anterior cruciate ligament is attached far back on the lateral condyle along the articular margin. Posterior cruciate ligament is attached far forward on the medial condyle. Again, you see this. This is posterior. This is anterior cruciate ligament. Medial condyle possesses on its convex non-articular medial surface a shallow pit for tibial collateral ligament. It is the medial epicondyle. Above it is lying the adductor tubercle at lower end of the medial supracondylar line. Medial head of the gastrocnemius takes origin from the back of the medial condyle and the adjacent popliteal surface of the femoral surface. So you could see now the adductor tubercle, right? This is the adductor tubercle for the attachment of gastrocnemius medial head. This is the attachment of the gastrocnemius origin, medial head. Here you could see, again, it's a different picture for the interest, right? This is adductor magnus. I showed you already. This is the gastrocnemius medial head. Lower end of the femur continues. Lateral condyle possesses three smooth floored pits placed vertically towards back of its non-articular lateral surface. Upper pit is meant for lateral hand of the gastrocnemius. Above this, plantaris takes origin from the lateral supracondylar line. Right? This is the lateral head of the gastrocnemius, right? This is the lower end of the femur. This is the plantaris as well, above that. Central bit lies at the prominence of the convexity of this surface and is termed as the lateral epicondyle, to which the fibular collateral ligament gets attached. Lowermost bit gets a popliteus tendon, a groove behind this bit gives place to the popliteus tendon when the knee gets flexed. Right? This is the popliteus muscle attachment over here. Now the surgical approach, shaft is to be exposed from front between rectus femoris and the vastus lateralis, as vastus intermedius is incised vertically down to the bone. A lateral approach is carried out by splitting vastus lateralis. And now a posterolateral approach is in front of the biceps, where vastus lateralis is detached from the front of the lateral intermuscular septum and following it down to shaft. And the last, ossification. Except the clavicle, femur is the first long bone to ossify. It ossifies in cartilage. A center in shaft appears at the 7th week of the interuterine life. A center for lower end appears at end of the 9th interuterine month at birth, and its presence is acceptable medico-legal evidence of maturity, right? Lower end is very important. It's acceptable medico-legal evidence of maturity. Lower end is growing end of the femur and the epiphysis, which biceps adductor tubercle gets united with the shaft after 20 years. A center gets appeared in femoral head during the first year after birth, in greater trochanter during the 4th year, and in lesser trochanter at 12 to 14 years. These upper epiphyses get fused with the shaft at 18 years of age. Thank you very much for watching my video, and I request you to subscribe my channel and press the bell icon, as tibia and fibula videos will be uploaded very soon now. Thank you very much. Take good care of you. Goodbye.